Seizure in childhood. A seizure is a sudden, uncontrolled body movements and changes in behavior that occurs because of abnormal electrical activity in the brain. The International League of Association Against Epilepsy operational classification of seizure types divides epileptic seizure into 4 categories based on the presumed mode of seizure onset. It is classified as focal, generalized, unknown onset, and unclassified. This is the updated classification of seizure in childhood. In focal seizures, the first clinical and EEG changes suggest initial activation of a system of neurons limited to part of one cerebral hemisphere. 2 types of focal seizure are there: focal aware seizure and focal seizures with impaired awareness. Focal aware seizure is when a focal seizure occurs with no alteration in consciousness, whereas focal seizure with impaired awareness is focal seizure with altered awareness of the surroundings. In general seizure, the first clinical and EEG changes indicate synchronous involvement of all of both hemispheres. A seizure may be labeled as being of unknown onset if there is not enough clinical information available to determine if the seizure is focal or generalized. We don't have adequate clinical information or imaging or EEG to say it is generalized or focal. We call at this time unknown onset, but later we can classify when we know the clinical information to categorize it. If the clinical characteristics of a seizure are unusual and the determination of onset cannot be made despite an adequate workup, the seizure may be labeled as unclassified. Approximately 30% of patients who have a first febrile seizure later develop epilepsy. This 30% risk is approximately 20% if the neurological exam, EEG, and the neuroimaging are normal in the first febrile seizure. Acute symptomatic or provoked seizure is a seizure that occurs secondary to an acute problem affecting brain excitability, such as an electrolyte imbalance, hypoglycemia, or CNS infection. Unprovoked seizure is one that is not an acute symptomatic seizure. Febrile seizures are defined as seizures that usually occur between 6 months to 5 years of age and are associated with fever, but without evidence of intracranial infection or a defined cause for the seizure. Epilepsy is defined as occurrence of 2 or more unprovoked seizures occurring 24 hours apart. Unprovoked seizures occurring 2 or more episodes 24 hours apart. Seizure disorder is a general term that is usually associated to include any one of several disorders including epilepsy itself, febrile seizure, single seizure, or symptomatic seizure. Approximately 4 to 10% of children experience at least one seizure, febrile or afebrile, in the first 16 years of life. The cumulative lifetime incidence of epilepsy is 3%, and more than half of the disorders start in childhood. If categorized by etiology, epilepsies are grouped into trauma, genetic, structural, such as tumor, vascular, it can be metabolic, immune, infectious, or unknown categories. It's important to note that these categories are not mutually exclusive, and a patient with epilepsy may have multiple concurrent etiologies. A single patient might have genetic and structural cause as an etiology for epilepsy. When we came to evaluation of the first seizure, the initial evaluation of a child during or shortly after a suspected seizure should include an assessment of the adequacy of the airway, ventilation, and the cardiac function, as well as measurement of temperature, blood pressure, and glucose concentration. These three should aim to determine if the event was a seizure or not and to provide a detailed description of the seizure and the child's post-ictal state. For acute evaluation of the first seizure, we should search for potentially life-threatening cause of seizure, such as meningitis, systemic sepsis, any poisoning or head trauma, and accidental ingestion of drugs or toxins should be considered. The subsequent step in an evaluation is to determine whether the seizure has a focal onset or is generalized. Focal seizure could include forceful turning of the head and eyes to one side, unilateral clonic movements beginning in the face or extremities, or sensory disturbance such as paresthesia or pain localized to specific area. Focal and the generalized motor seizure might be tonic, tonic-clonic, clonic, myoclonic, or atonic. Tonic seizure is characterized by increased tone or rigidity, whereas atonic seizure is characterized by flaccidity and the lack of movement. As you know, clonic seizure it consists of rhythmic, fast muscle contraction and a slightly longer relaxation. Myoclonus is a short, shock-like contraction of muscle for less than 50 microseconds that is often repeated. The duration of the seizure and the state of the consciousness, retained or impaired, should be documented during the seizure. Aura preceded the convulsion, and it is the behavior the child was exhibiting preceding the seizure. Auras can take the form of a number of sensations, including visual, such as flashing lights or seeing colors or complex visual hallucinations, somatosensory, olfactory, auditory, or experimental, depending on the precise localization of the origin of the seizure. The most common aura experienced by children is epigastric discomfort or pain and feeling of fear. The posture of the patient, presence of cyanosis, vocalizations, loss of sphincter control in the postictal state, whether during the postictal state there is paralysis, headache, or sleep should be noted and documented. In addition, a detailed history is crucial in identifying underlying cause for the seizure. Personality changes or symptoms of increased ICP can suggest an intracranial tumor. History of cognitive regression can suggest degenerative or metabolic disease. History of prenatal or perinatal distress or developmental delay can suggest etiologic congenital or perinatal brain dysfunction, such as perinatal asphyxia. The examination of a child should also be focused towards the search for an organic cause. The child's anthropometry should be taken, careful general and neurologic examination should be done, fundoscopic examination should be performed to evaluate for the presence of papilledema, optic neurites, chorioretinitis, uveitis, retinal hemorrhage, and the finding of unusual facial features or of associated physical findings such as hepatosplenomegaly may point to storage disease or inborn error of metabolism as a cause of neurologic disorder. The presence of a neurocutaneous disorder might be indicated by the presence of skin lesion on the body. In acute setting, the decision to pursue further laboratory testing should be made on a case-by-case basis. LEP is not needed in an acute workup of a non-febrile seizure unless the history or examination is concerned for an infectious or inflammatory process. EEG should be performed in all cases of a first unprovoked non-febrile seizure to help predict the risk of seizure recurrence. Emergent brain imaging with head CT or MRI is usually performed if the seizure was focal, if there are postictal focal deficits or postictal neurologic exam abnormality, if the patient status is not returning to baseline after seizure, if the history of trauma before the seizure and high-risk medical history. In those cases, we should have to take imaging. Brain MRI is preferred over CT scan. CT is useful if rapid study is needed to look for trauma, mass, or signs of increased ICP. When we came to treatment of seizure and epilepsy, designing or long-term therapy after a first seizure, if the risk of recurrence is low, for example, when the patient has normal neurodevelopmental status, normal EEG and MRI, treatment is usually not started after the first seizure. However, if after first seizure there is abnormal EEG or MRI, developmental delay, abnormal neurologic exam, positive family history for epilepsy, or if two or more unprovoked seizure is there in more than 24 hours, the risk is higher and the treatment should be started. Drug therapy should be based on type of seizure, the epilepsy syndrome, and other individual factors. For example, if it is focal seizure or epilepsy, carbamazepine is the first-line anti-epileptic drug. In the case of absence seizure, ethosuximide is the first line. Generalized tonic-clonic and the mixed seizure can be treated with valproate, phenobarbital, phenotane. Juvenile myoclonic epilepsy can be treated by valproate or lamotrigine. Infantile spasm should be treated by adrenocorticotropic hormone, and the Lennox-Gastaut syndrome can be treated by lamotrigine, topiramate, and valproate. Other issues to have in mind while selecting anti-epileptic drug include comparative tolerability, cost and availability, drug interaction, the presence of comorbid condition, history of period response to specific anti-epileptic drug, mechanism of action, and the ability to monitor the medication and adjust the dose. In non-emergency situation, start maintenance dose and then gradually increase. Monitor by baseline laboratory studies, including CBC and organ function test. Laboratory monitoring is more relevant if in the first 3 to 6 months of therapy. Monitor for drug side effect also. Only one drug should be usually initiated, and the dose increased until complete control is achieved or until side effect profit further increase. Then and only then may other drug be added and the initial drug subsequently tapered. Control with one drug or monotherapy should be the goal, although some patients eventually need to take multiple drugs. Drug-resistant epilepsy, those who have failed at least 2 fair trials of appropriate medication need further workup and management with possible combination therapy, steroid, IVIG, ketogenic diet, vagal nerve stimulation, and even epilepsy surgery. Once started to discontinue anti-epileptic drug, at least the child should be free of seizure for 2 years. EEG and the neurological exam should be normal, and the anti-epileptic therapy should be discontinued gradually, tapered over 3 to 6 months. Abrupt discontinuation can result in withdrawal of seizure or in status epilepticus. If seizure reappear after discontinuation, initiate the last drug and the dose discontinued that used to control the seizure. Most relapse occur within the first 6 months after discontinuation. Thank you for watching.